And now to the keynote lecturer, Professor Barry Coller, David Rockefeller, Professor of Medicine, Physician-in-Chief and Vice President for Medical Affairs at the Rockefeller University in New York. The combination, one moment please, the combination of a great physician and an outstanding researcher is not common. Barry exemplifies one. And Uri also, he was an outstanding physician researcher, a world-renowned one. And here is a small and typical example. About 12 years ago, while in New York, we, my late husband Amiram and myself, were invited to a nice party in Westport. The host was Arturo Constantino. Remember? And we were introduced by our host, and I cite, to one of the greatest physicians in the world. This very person is our keynote speaker, Professor Barry Coller, a world-renowned hematologist. When Barry and his wife Bobby, they are both here, heard that I was from Tel Aviv University, they excitedly and curiously asked if I knew their personal friend, Uri Seligsohn. You can imagine that from that second, the entire conversation focused on praising Uri and Hani, and there was no limit to our joy. I'm very happy that Professor Barry Coller is here, and we can go on talking about Uri and his extraordinary scientific contributions to hematology. Professor Coller's interesting title of the talk is From the Rivers of Babylon to the Coronary Bloodstream, How Professor Uri Seligsohn's pioneering research lives on in modern cardiovascular therapy. Please, Barry.
I want to first start with my disclosures so that I make sure that I cover this. I will be talking about several of the items on this list, so I want to just make sure that everyone has that information. I was honored by the Academy's invitation to celebrate the life and remarkable scientific and medical achievements of my dear friend and really esteemed colleague, Uri. It's particularly meaningful that we're today reunited with this entire wonderful Seligsohn family, and our relationship with that family grew from my relationship with Uri, and we're so happy that Hani and so many of the family are here today. In reading about the history of the Israel Academy of Sciences and Humanities in the 2021 exhibit, I was struck by this quote from Professor Katzir, that he was concerned that scientists at a time when the impact of their work was constantly increasing were withdrawing into their ivory towers, unwilling to take social and moral responsibility for the outcomes of their research. I can tell you that Uri Seligsohn, as a physician-scientist member of the Academy, really epitomized the integration of science and humanities. More than a decade ago, I spoke at the Academy about the importance of training and supporting physician scientists, and I am delighted that there is increasing support of physician scientists in Israel. I will move quickly through these slides because you've already heard so much about Uri, and I don't want to just repeat them. And I'll just highlight a few things that I think are particularly important in his career and in his life. My dear friend Shmuel Bernstein was in the Suez Canal area when he took this picture of Uri receiving an IDF promotion. And I must say, one of the themes that ran through our relationship was understanding Uri's devoted service to the IDF for many years. I remember many years later discussing with him the preparations for Scud missiles and what he was doing to ensure the safety of patients at Ichilov. You've heard a lot about his scientific contributions, and the speakers later will go into some of the really important ones that I will not be touching on. And you've heard about his awards, and I would point out especially the election to the Israel Academy of Sciences and Humanities, and I know how prestigious and how important that was, and also the Grant Medal, literally the highest honor of the International Society on Thrombosis and Hemostasis. He also, as you've heard, held many leadership positions, but the one that I really want to focus on is the last bullet here. He was the president of the 1995 conference of the International Society, which was held here in Jerusalem. And I can tell you that that was a monumental event. It was a monumental event for Uri. It was a monumental event for the field of hemostasis and thrombosis in the international community. And I still have these wonderful, wonderful memories from that meeting where every detail had been absolutely precisely organized to ensure that the scientific quality was absolutely outstanding, but also the history of the country and the importance of understanding so much about Israel was brought to the international community. David spoke about William's hematology. Even though English was not Uri's first language, he was a brilliant writer and a really critical and analytical editor. And as a result, we had the great pleasure of working together on this major textbook. And this is a picture taken from 1997 with us around the table discussing all of the different chapters. Uri actually did 3 sabbaticals, short ones, with me, one at Stony Brook and then 2 at Rockefeller University. And much of the later ones were focused on doing the editorship for this major textbook. So the themes of our relationship in terms of our direct scientific collaborations were really the following. First of all, the value of deep phenotyping, which was demonstrated Uri's enormous and wonderful capabilities as a caring and dedicated physician, but also his ability to adapt and integrate, as you heard from David, new technology. That was the excitement of being able to use every new tool to better understand disease and to have an impact on patients. For me, it was the joy of having an ideal collaborator. I can tell you that one of the most powerful things about being a scientist is when you have a sense of resonance with another scientist. That relationship is very precious, and it isn't easy to achieve, and it doesn't happen just by chance. But working with Uri and having our relationship was really one of the most important aspects of my entire scientific career. Also, as a diaspora Jew, to actually have the opportunity to work in the land of Israel was extremely meaningful to me. So let me start with the rivers of Babylon, and it really starts with deep phenotyping. Here's one of the major early works on understanding Glanzmann thrombocythemia, this rare disease in Israel. And you can see that Uri published this paper with Bracha Ramot. And I eventually worked with Uri. I did a mini sabbatical at Mahon Weizmann back in 1982, and that's when we were able to begin to think about what kind of collaboration we would do. And one of the patients that I met as part of that was a 40-year-old woman from the Iraqi Jewish population, and she had a lifelong history of easy bruising, heavy periods, gingival hemorrhage, GI hemorrhage, and she had already needed over 200 platelet transfusions to control her bleeding. And her platelets really just didn't do what platelets are supposed to do. They're supposed to clump together when you activate them with any one of these activating agents, and they just didn't do that. But now let me go back to the rivers of Babylon. And this is the campaign of Nebuchadnezzar II that ended in 586 BCE and obviously ended in Jerusalem, and then the bringing back of many, many Jews to Babylon. And as a result of this, we have from Psalms, the rivers of Babylon, we sat and wept when we remembered Zion. If I forget you, O Jerusalem, may my right hand forget its skills. Cyrus, in one of the Iran-Iraq wars, then in 539 BCE, was able to loosen the restrictions on travel and establishing religious activities, and made it easier for Jews to return to the land. But in fact, not all did, and many, in fact, stayed. But things then turned rather unpleasant for the Jews in Iraq. In 1941, there was a military coup, and there was a pro-Nazi government and pogroms. The 47 petition plan led to serious problems in the Jewish community. And by 1950 to 52, Operation Alibaba and then Operation Ezra and Nehemiah airlifts 130,000 Iraqi Jews to Israel. And of course, this is Ezra reading the Torah with the return to Jerusalem, just as in the return of the Babylonian Iraqi Jews in the 1950s. And now back to our platelet abnormality. You can see here, ordinarily, when you add ADP, the platelets clump, and that leads to this change in the aggregation tracing that shows that the platelets are clumping together. But the patient's platelets don't do that. And it's not a problem in the ADP receptor, because the same thing happens if you activate with another activator. And so there's something downstream of this activation that's abnormal in these patients. And by the 1970s, when SCS gels became the rage, we were able to actually establish that, first should recognize the work of other groups in identifying the deficiency in alpha-2b over here, one of the proteins that's missing. This one's harder to see because of overlapping proteins, but there's another protein missing over here. This is one of the patients that Uri and I studied. And you can also see that there's an abnormality up here, a missing band that relates to the protein fibrinogen. And in 1982, we were first able to make monoclonal antibodies, and our laboratory made an antibody called 10E5 that actually could do exactly to normal platelets what was the defect found in the patients. And that is, if you added this antibody, it was blocking the ability of something to be able to actually lead to aggregation. And the pattern was very, very similar. And sure enough, this antibody was recognizing the receptor, the alpha-2b beta-3 receptor. And so Uri and I went on to do a whole series of studies, of which I'll only be able to show you a small sample. But here we use that same antibody to show that normal platelets, or platelets from normal people, will bind about 40 to 50,000 of these antibody molecules, and they're binding bivalently, so they're actually about 100,000 receptors. Obligatory carriers of the disorder, the parents of children who had the disorder, were somewhere in the middle, and the patients bound virtually none of the antibody. And this allowed us to do the first analysis, and ultimately it allowed us to do the first prenatal diagnosis using the monoclonal antibodies, with patients going to England to have pure fetal blood taken at a time when that was a very difficult technique to achieve by our collaborators there, Reuven Mibashan, hematologist trained here, as well as very talented obstetrician, Mr. Rodek. And this was a really major breakthrough. And we had the great pleasure with Uri of visiting one of the families here. And this allows me to personally attest to tell you just how beloved Uri was as a physician and how dedicated he was as a physician. And this really was just a wonderful, wonderful experience for us. There were different groupings of individuals who had the Glanzmann thrombasthenia in Israel, a group of Arab patients and a group of Iraqi Jewish patients. And the first study that we did that began to allow us to understand the differences at the molecular level was by immunoblotting, to be able to see that the patients from the Arab population had a little bit of beta-3, whereas the Iraqi Jews had essentially none. And that ultimately led, as you heard, about our collaboration with Peter Newman, in which we were able to actually now, using the advanced technique of polymerase chain reaction, to identify the specific abnormality. And this was possible both for the Arab variant, which was in the alpha-2b chain, and the Israeli, the Iraqi Jewish Israeli abnormality, which was in the beta chain, beta-3 chain. And this is an old stick diagram just so you can get some idea of how complex these receptors proteins are. And over here was the small deletion in the Arab variant, and over here was a small deletion in the Iraqi Jewish variant. And this then allowed us to move on to do the prenatal diagnosis by chorionic villus sampling at 11 weeks of gestation rather than at 18 weeks that was required with the previous techniques. And so this is just giving you a little taste of the many experiments that we did. But I was asked today to also speak about how this work influenced the subsequent work in our laboratory related to the coronary bloodstream. And I want to again start with the deep phenotyping, because it was based on the studies with Uri that we understood that the following was very important as parts of understanding this disorder, and that was that the carriers are really without symptoms, so having half the amount of receptor is actually quite protective. The patients have variable types of bleeding, but in fact, if I go down over here, the most important thing is that spontaneous bleeding into the central nervous system, into the brain, was very rare. And that contrasted with other disorders, including hemophilia, and said that maybe you could actually inhibit this receptor in a way that would allow you to have an impact on thrombotic disease without necessarily having unacceptable bleeding risk. And you've already heard that ischemic heart disease is the #1 killer in the world. This is now global. This is now global data, and the number of deaths you can see between ischemic heart disease and stroke. Both of these are thrombotic diseases in which platelets play an important role. And just to emphasize that this is actually no longer just a disorder of the Western world. I'm just showing you from 2002 to 2016, the mortality rate for heart attack in China. And you can see that this dramatic increase 4- or 5-fold over this very, very short period of time. And I think we need to be paying a lot of attention to the increasing risk for thrombotic diseases in low and middle income countries. And of course, this is what happens. There's a clog in the coronary artery, and as a result, the region over here doesn't get enough oxygen, and when that happens, the heart muscle dies. And there are two separate processes. One is the atherosclerotic process, where all of this material in here doesn't belong there. This should all be white. But this, in fact, rarely kills someone by itself. It's the clot that forms on top of it that's really the major problem. And if you can reverse that closed artery quickly, you can actually protect virtually 100% from dying. But you can see how steep this is, and over a period of just a few hours, if you don't reopen that artery, you're going to have more and more serious loss of heart muscle, and as a result, a higher rate of mortality. And the current therapy in high-income countries is to, as rapidly as possible, get the patient to some place that can actually insert a catheter with a balloon, and then the balloon can deploy this stent that opens up the artery and keeps the artery open. But it's not so easy to keep an open artery in the face of additional thrombotic risk, because the minute you put in the wire over here, you're going to expose proteins that the platelets will sit down on. And so here are the small platelets that we see over here compared to white blood cells and red blood cells. And these platelets have the capacity to not only circulate, they actually circulate more or less as a pita shape, if you will, but then when they get activated, they extend these filopodia that are very extensive, but then they start to interact one with another. And this is the activity that the patients can't undergo, and potentially that we could block with one of our antibodies. And so here's the overall paradigm that is an oversimplification, to be sure, but provides some of the key issues. Number one, you have a lining of the blood vessel, but if you damage the blood vessel in any way, you'll expose proteins that platelets have receptors for, and so platelets will stick down. Then there's an activation process, and this one receptor that we're talking about undergoes a major change in its shape, which allows it to bind that protein fibrinogen that I showed you that was missing. And when that happens, you can actually have the platelets coming together like this to clump and support coagulation. And now, of course, we know a lot more at the molecular level, and this is taken from crystal structures now, where we have the different parts of the alpha-2b subchain, and this is the beta-3 subchain. And you can see over here is where the fibrinogen binds. And we now know that the fibrinogen binds with on either end, the fibrinogen molecule is actually made up of two identical halves. And so this can bind to one platelet, and this can bind to another platelet. And this is the way they fit into the pocket up here. And I just want to point out two things about the way it fits in. Number one, there's a lysine, a positively charged group over here that interacts with a negatively charged group in the alpha-2b. And over here, there's a magnesium ion, and there's an aspartic acid that has a negatively charged carboxyl group that interacts with the positively charged magnesium ion. And if you wind up disrupting the lining of the blood vessel, what you see in a normal mouse whose carotid artery to the brain is a little bit, about the same size as the narrowed coronary artery after it has atherosclerosis. All of this white material is just wall-to-wall platelets heaping up, and within 6.5 minutes, it will be completely occluded. And as a result, you can see how rapidly this process can result in the blood vessel closing. On the other hand, this is a mouse that lacks that receptor, and you can see here that in 5 minutes, there is no white, and in a second, you'll see that after waiting a full 20 minutes, there still is no white, because the platelets simply can't interact. And early on, we wanted to show that this was stronger than aspirin, and as a result, you can see from this experiment that arachidonic acid can cause platelets to aggregate, and I'll go into more detail about that in a second, but aspirin completely blocks that. But if you use another activator, in this case ADP, you can see that even the aspirin-treated platelets don't work. But if you have another one of our antibodies that blocks the receptor, you can see that that completely prevents the aggregation. And so we worked initially with a murine antibody and then with fragments of it, and eventually with the scientists at Centocor converted it into a chimeric FAB fragment. This was the original murine portion. This is the human portion. And this is actually the drug abciximab. And if you add more and more of this to the platelets of, in this case, a non-human primate, but the same thing is true of humans, you get more and more blockade of the receptors, and about 80% blockade is really what you need to more or less eliminate the aggregation. And you can do the same thing either, this is now in the test tube, this is just by adding more and more of it to the animal itself, and you get the same response. And so we could begin to learn a little bit more about where our antibodies bound, and we could see that our antibodies were binding right over here and probably blocking this is the abciximab, blocking the receptor from being able to bind the fibrinogen. And now years later, we have the ability by using cryo-electron microscopy to actually have a molecular understanding of exactly where this is interacting. And so this is the paradigm. This is the platelet. And there are many different things that can activate. I've told you already about the ability of arachidonic acid to do it by virtue of it resulting in the generation of thromboxane A2, and this is what aspirin blocks. There are ADP receptors for which we have some inhibitors. We have thrombin receptors that can activate. We have other agents like collagen that can activate. The key point, though, is all of these work by causing that conformational change in that receptor over here, so that this is the final common pathway. And so even if you activate by multiple pathways, you will be able to block the aggregation by working down here. And abciximab was approved for human use back in 1994, and 2 small molecule inhibitors were also approved soon thereafter. And if you take a look at the data from over 40 clinical trials with over 33,000 patients, you could see that you could reduce the risk of dying by something like 30%, and you could reduce the risk of either having death or a heart attack by a similar amount. There was an increase in bleeding, and I'll come back to that in a minute. So these drugs have been given to about 10 million patients overall, with probably about 5 million with abciximab, and now we're probably up over more than this number with the other 2 agents, with a 2.6% absolute risk reduction in heart attack or death at 6 months. And that would translate into about 260,000 patients spared of dying or having a heart attack. And of course, there have been advances in antiplatelet therapy since then. And so one of the questions is, well, this is old data. What about with the modern technologies and the modern drugs? And they did a very interesting study in England quite recently in which they found that some of their doctors used these drugs a lot, and some of these doctors didn't use these drugs very much at all. So they said, well, let's just compare the outcomes from these 2 groups. And when they did that, they found that those who used routine use of the drug actually had better outcomes and had lower mortality than those who only used it when in selective cases or when they got into trouble. And this was their conclusion, that in fact these drugs are still effective even with other modern therapy. The bleeding risk was not trivial, to be sure, early on, but one of the big advances that occurred was that, so these are the patients who got the drug, and these are the control patients, and you can see on average that these are more bleeding occurred over here than over here. But things got better for the whole field when people moved from doing the procedures from the leg and using the hand vein, or the hand artery, rather than the leg artery for the catheters. And you can see then that even when they're getting the drug, the rate of bleeding has decreased significantly. I like to show this, especially when we go to Capitol Hill to talk about funding for research. I was around when Eisenhower had his heart attack back in 1955. It was a calamitous public event. The stock market crashed. The public was really very, very concerned. He got these drugs, and he also got the key therapy at that time, which was bed rest. And most people got 6 weeks of bed rest. He got 7 weeks because they didn't like what happened when they let him sit up in the first week. And you can imagine how deconditioned people became and how subject they were to venous thrombosis because of their immobility. And the mortality was somewhere between 30 and 40%. When Cheney was vice president-elect and had his heart attack, he was in the angioplasty suite within a couple of hours and got these drugs, almost certainly got these drugs as well. He walked out of the hospital in less than 2 days, and he was back at work in less than a week. And mortality is dropped to 1 in 20 rather than 1 in 3. And of course, Bernie Sanders had a heart attack, which slowed him down for about an hour and a half, but certainly has not ended his career, as it had a major impact on Eisenhower. Didn't end his career, but had a major impact on the entire country. And certainly there were many patients at that time in the United States who were what we would unfortunately call cardiac cripples, where they couldn't, in fact, function well because they had so much diminished cardiac function. And these drugs also turned out to be quite useful in neuro interventions. Now we're doing more and more interventions for problems in the brain, including aneurysms, using stents. But sometimes the stents lead to the generation of thrombosis because you can't put in a stent without activating some of that platelet deposition because of the damage to the endothelium. And then over here, you can see this is a closed artery, but when they gave the drug abciximab, you can see that the artery opened quite quickly. And this was one case study that they found was either complete or partial resolution of the thrombosis was observed in 100% of the 30 cases that were studied. So what is the current real need? Well, this is really where we're still not doing as well as we can. Of the people who die from a heart attack, about half die within an hour of their first symptoms and before they reach the hospital. And you can see here that in-hospital mortality, these are data from Sweden because it's hard to find data from other places. This is the in-hospital mortality, and you can see that it's dropping and dropping and dropping from the 1990s and started dropping a little bit earlier than that. But you can see the out-of-hospital mortality remains still remarkably high and not changing very much. So we have about 275,000 people in the US dying before receiving medical care. Most of them actually have symptoms for more than 30 minutes. And there are 150,000 who have documented what these are called SC segment elevated MIs. These are myocardial infarctions that are particularly severe. And we also know that if you open up the blood vessel, either with one of these antagonists or with the platelet antagonists, that you can actually reduce mortality, infarct size, and later heart failure. And this was the first study that suggested this. It turns out that this study showed that if you got abciximab versus placebo, overall there was a 53% reduction in the frequency of having death, reinfarction, or urgent revascularization. If you look to see of this group, the ones that actually got treated just before they got the procedure, it was a 31% reduction. But those who got it very early, either in the ambulance or in the emergency room, their benefit was much greater, suggesting that earlier will be better. And here's another study showing the same thing. TIMI 3 flow is essentially an open artery, and TIMI 0 flow is no opening of the artery, and this is combining TIMI 0 and 1. So you can see that the patients over here who got apixaban in the ambulance, 28% of them came in with TIMI 3 flow compared to 7% in those who did not. And you can see the same sort of data in many different studies showing the importance of opening things quickly. And this shows a study from Dr. Gold that within 10 minutes of giving a bolus dose of apixaban, they could see recanalization of one of the major coronary arteries. And in this study in particular, there were a lot of patients, 9 patients came in with no flow in their blood vessel. One patient within 10 minutes had TIMI 3, and you can see 3 had TIMI 2, and 4 had TIMI 1, already showing the beginnings of recanalization. So it's clear that it's possible to do this, and just one additional example of 5 minutes after an apixaban bolus, even large thrombi occasionally can be seen to be reversed. And so patients who not only get that reversed, but who get treated early wind up having much better long-term prognosis. So this is 11 years. This is a remarkably long follow-up. But you can see that the people who got treated in less than 65 minutes compared to those who got treated after about 3 hours, not only is there a lower frequency of mortality early on, but you actually get increasing benefit over time, with this being close to 30% mortality at 11 years compared to roughly 3 or 4% mortality. So what would be an ideal antiplatelet agent for early therapy? The 3 agents that I talked about all have to be given intravenously. They're given as a bolus, and then they have to be given by continuous infusion. And that's a challenge. So what you'd like is something really potent, but it'd be nice if you could give it subcutaneously to make it easier for it to be given. That means you just, like an EpiPen, can just inject it under the skin. You want rapid onset. You want it not to last too long so that you don't wind up with limiting the risk of hemorrhage. And if you're going to want to put it in like a auto-injector EpiPen, you have to have it soluble enough so the dose that you would give even the heaviest person that you want to treat has to be in a very small volume. And finally, I'll talk just a little bit here about the science, because now we know a lot more about this receptor, and we know that some of the agents out there actually partially activate the receptor, and it would be good if we didn't do that, and I'll try to explain this in a couple of slides. So we know that when you activate the receptor, it undergoes 2 major conformational changes. It undergoes extensions because normally it starts out in this compact bent form. And then this portion over here swings out. And when it does that, it puts the receptor in a high affinity binding mode. And remember I showed you in fibrinogen that there was a positively charged group and a negatively charged group on either end? Well, it turns out the 2 small molecule inhibitors of the receptor have the exact same type of overall structure. And this is about 17 angstroms between them. And so the way they bind is just the way the fibrinogen binds. The positive charge interacts with alpha-2b over here, and the negative charge interacts with the positively charged magnesium over here. And it turns out that these drugs themselves will actually drive the activation process. And so the question is when that happens, it's a real challenge because that puts the receptor in the active conformation and exposes regions that are ordinarily not exposed. And without going into all of the details, this is that carboxyl that comes into the magnesium. And when that happens, you get a change over here and a shifting of this calcium ion in this direction. And believe it or not, that then leads into a Rube Goldberg type of process in which you can watch the unfolding down over here as the molecule binds and reorganizes the configuration around this particular calcium ion. And when that happens, there is a major conformational change downstream. And Rube Goldberg mechanism here, you'll see in a second that, in fact, as this moves over, you wind up breaking this bond over here, and that allows this area over here to unfold and undergo a major change. And if you look at this on this scale, looking at it over here, you can see just how dramatic that change is. So one of the reasons that it would be good to avoid that is because some patients wind up with a low platelet count, about 1 to 2%. And that's probably because the antibody can bind to regions that are exposed when the platelet gets activated by these small molecules. And when that happens, the antibodies will lead to the removal of the platelets. And so quite a number of years ago now at Rockefeller, we decided to look for new molecules that could inhibit platelets binding to fibrinogen. And we did that after 33,000 were screened. We were able, in fact, to find one that looked interesting. And it could inhibit platelet aggregation. And that model that I showed you of the neck, where the carotid artery with the closure within 6 minutes, you could see that this drug could actually completely protect against that process. And then we looked to see where this was binding by computation, and then by X-ray crystallography, we're able to confirm where it was binding. And then we started to make variants of this molecule, and in particular, RUC2 was particularly interesting. And that got us about 100-fold higher affinity. And so we could use less and less, which was really important because we're now in the region where it's drug-like, where there is enough affinity for it to actually be considered for a drug. What was quite amazing to us was, remember I showed you that this negatively charged group interacts with the magnesium, but this particular molecule didn't have a negatively charged group. It didn't follow this model. And really what it was doing was it was binding to the molecule over here that holds the magnesium in place. So it was kicking out the magnesium, so there's no magnesium, and therefore it can't bind the fibrinogen, and you can't bind any of the ligand. And then we went on to make a congener of this that was soluble enough for our purposes, called RUC4, and we were then able to show that it's quite effective in inhibiting platelet aggregation, and in fact more effective than the current drugs in inhibiting aggregation induced by activating through the thrombin receptor. So drugs that inhibit the ADP receptor are good at inhibiting ADP-induced aggregation, but not thrombin-induced aggregation, whereas this particular RUC4 molecule was able to inhibit not only the ADP in the aggregation, but also inhibit the aggregation by the thrombin receptor. These are both thrombin receptor activation. You can see how little inhibition there is here, whereas there's much more inhibition over here. And this drug was also able to prevent the thrombus in the carotid artery of the mouse. And in this model, we were able to show that compared to no drug, the RUC4, like abciximab, allowed only one layer because the platelets can still adhere by those other receptors. They just can't bring new platelets into the process. And by then, we could then move on with the company called Seligsohn to begin to do human subject studies. And we started with healthy volunteers and then patients with stable coronary artery disease on aspirin. And we could see that within a couple of minutes of getting the drug, these are 2 different doses, that we could see that we could essentially completely inhibit or get close to inhibiting the aggregation response. And over a period of a couple of hours, this was back nearly to normal. And even patients on aspirin, which is a drug we would want to use in combination, did not show any excessive bleeding. And then we went on to do a similar study in patients who were actually having a heart attack. And these patients showed, again, a similar dose response as we moved up the doses. And again, now we're over 90% inhibition. And again, coming back over the first 2 hours to nearly normal. And so the goal of our new therapy is very early therapy to inhibit platelet aggregation, and then rapid wear off while the other agents that come on that don't need to be as potent and therefore have lower bleeding risk begin to take effect. And in this study that I just showed you, when we looked to see whether or not patients had TIMI grade 2 or TIMI 3 flow, you can see that the ones who got a dose that was below our target of 80%, only 1 out of 7 actually wound up with a TIMI 3 flow greater than TIMI 3 flow of grade 2 or 3, whereas those who got the doses that met our target, 6 out of 9 and 7 out of 8, showed the TIMI 2 or TIMI 3 flow. And similar other indices of whether or not the heart is getting perfused properly and whether the size of the thrombus showed the expected results that you would anticipate. And so this has now led us to have the ability to do a phase 3 study that is designed for enrolling 2,499 patients who are having an ST segment elevated myocardial infarction. And the patients either get a placebo or RUC4, or now called Zalenfiban, in the ambulance. And of course, our ultimate dream is to deliver our agent to the home after you send your EKG to your doctor with your smartphone, or maybe even have this at home. So I think that this is our goal, and just say that there are other opportunities, and I really want to emphasize treating myocardial infarction in countries with limited access to coronary artery interventions, I think is going to become increasingly important, and we hope that we can do something valuable there by making it easier. Patients who recover after having external defibrillation, that can be a problem, and there are some of those patients will in fact show signs of a heart attack who might be treated. And there are already in the United States 16 million Americans who've already had a heart attack, and so we might want to keep a drug like this available. I love the first slide of Uri, but this is the one that is most emotive for me, because this is really how I remember him, sitting across the table, discussing ideas, discussing family, discussing how to make the world better. And it's his legacy that I'm so happy to be able to recognize today and to share my thoughts with you. I'd be remiss if I didn't acknowledge the small army of people who did the work that I had the chance to show you today. So please indulge me as I at least walk through the slides to make sure that you realize just how complicated and complex it is to actually go from an idea to a phase 3 study. It takes an army of people to achieve that, and I want to be respectful of that. So again, thank you so much for the opportunity to speak to you today.
Thank you, Barry, for an inspiring talk. And if there are any questions, Barry will be happy to respond. Are there any? Yes, please.
Yes. In the study of women, there's a discussion of, you mentioned of fetal blood. And my understanding that blood, if we talk about hemoglobin bearing oxygen, doesn't occur in any great degree in the body until just before birth, when the erythroblasts explode in the bones of the emerging infant, and then they go into the bloodstream. So what is this blood, this fetal blood that you're referring to? Am I correct in my model, or is there some other blood?
So fetal hematopoiesis gets started relatively early in the yolk sac, in the liver, and then finally in the bone marrow. But when a fetus is born, or even during gestation, the fetus has blood, and the blood has blood platelets quite early on. But their hemoglobin is also normal. They're not severely anemic. In fact, often they're born with elevated hemoglobins. So there's a complex switch of hemoglobins. There's actually fetal hemoglobin that then starts to disappear as adult hemoglobin starts to be made. And that switch is very important and actually is one of the targets for treating sickle cell disease, because it turns out that sickle cells that have a lot of fetal hemoglobin don't sickle so much. So now gene therapy is being used with CRISPR to try to prevent the switch and keep a higher level of fetal hemoglobin. But there is a very structured program, but their hematocrits are quite good throughout that period.